streamed on Teams and recorded for then to be put on our website. So welcome to particularly anyone who's joining on Teams, members of the public, partners, and I've got apologies from Mark Caulfield, but he will join us for this afternoon. Martin Phillips and Ruth will join us partway through this morning's meeting. And Catherine Halford's apologies. Beth Williams ably substituting for Kath as a deputy, for Catherine rather. And Catherine sent me a lovely picture with her new granddaughter in Australia. So we wish her mother and granddaughter doing really well. And Ron has sent apologies as well, who is the chair of our Patient Partnership Council. Really pleased that we can start the meeting with journey of a young person requiring placement. And welcome to Emily. It is really important for us to hear, because we know of the challenging circumstances and the difficulties that we do experience in finding placements for young people. It's a big risk and concern for ourselves. So can I hand over to Beth and Emily?
Yes, sure. Thank you. So actually I'm going to hand straight over to Emily, who is the head of nursing for Children's Services. So Emily has prepared this presentation as an example of some of the experiences children and young people have in our emergency department. So, Emily?
Thank you, Beth, and thank you so much for inviting me today. It's so important that we are recognising this really important journey of our young people throughout the HIUT. So I'm really grateful to be able to come along and present this to you. So my name's Emily Bell and I am the Head of Nursing for the Children's Directorate. So here's on behalf of the team today. And the areas that I cover within the role are now, as part of our Children's Directorate, our Children's Emergency Department, which merged within our Directorate earlier this year, and also our acute areas and our day-to-day and the CYPAU areas. So firstly, just as a bit of background really, if you go to the first slide, please. Lovely, thank you. So it's recognised nationally that mental health admissions for both adults and children are on the increase throughout the whole of our country. And over the past decade, there has been a significant increase in the need of support for our children and young people, both acutely and within our community. As we've shared, the HIUT has seen an increase in these children and young people that are being admitted through our Children's Emergency Department and coming to us with a non-medical need. So they're coming in and they don't actually need any medical support from us while they're in our trust. These young people do sometimes require one or more nights of stay with us, increasing their length of stay. And I'll go into more detail into that a bit later. And that's to ensure we're facilitating a safe discharge for them when they leave our trust. When they're with us, these young people do require a multidisciplinary approach. It's a real collaborative approach, and hopefully I can show you that through this presentation, how we're working through all of our areas with our internal and our external stakeholders to ensure we have a safe journey for these young people that is facilitated. Next slide, please. So if we just look at our statistics, I think it's really important because this really highlights where we are. Before I go into them, I'm just going to explain about how we record our data for our children and young people. So when our patients come into our Children's Emergency Department, they are triaged and they are placed into a category for their admission. So it's what the need is for that young person on their admission. And for our children and young people that come in, either in a mental health crisis or with a behavioural escalation or outburst, it is classed as a mental health admission. So all the data we collate, these children, even if they're discharged by mental health services, are still classed as mental health admissions. And they will remain under this classification following their assessment and discharge and moving through the services while they're in trust with us. So our data here really well reflects where we are as a trust. So the graph on the left shows us that our peaks and troughs of our mental health admissions We have our young people who do come to both of our sites. They come to both the Queen's site and the King George's site. But as we'd expect, we have a higher volume of admissions for our Queen's site, and that is for different reasons. But some of those being that we don't have any ambulances taking children to King George's, so our ambulances bring our children to Queen's. So if they're being brought in by ambulance, predominantly they're always brought in to our Queen's site here. So that's why our blue line reflects our higher volume of young people coming through our Queen's. But you can also see here the increase we've had. So it starts in October 22. We do have peaks and troughs, and they generally reflect from different times for us. It can include when children are returning to school after the holidays, and different times when mental health does escalate for different reasons, for different triggers. And that does really reflect here. But you can see the trajectory in our Queen's site that we have had a continued grow. And in our peak times, it's generally, on average, 10 children per month now increase per year for our admissions. And then moving on to the other side, we're looking at our length of stay of our young people. Oh, sorry, the slide, sorry, thank you. We're looking at our length of stay of our young people here, and this data reflects that for us. So you can see that our grand total over the last year for our children that were seen under this category over both sites was nearly 1,000 children. So that really shows the impact that we are facing within our children ED departments managing these young people. Our longest length of stays, as reported up, does go above. For 4 of our patients have stayed longer than 30 days since August. And this has huge pressure on us as a trust, as a department, and on these young people. And it also has a huge pressure on our external services. So as written there, we've had 4 that have stayed between 10 and 16 days within this period of time. And we have seen this increase, as it reflected there, of these young people over the last year. Thank you. I thought it'd be a really good idea to kind of talk you through the journey of a young person. So this is a hypothetical person that we brought in for this scenario, but this actually is what we see on a really regular basis for us. So we're going to base it on a 14-year-old young person with autism who is cared for in a looked after child placement. Quite often our young people who aren't able to be managed at home are cared for in foster care placements, and their class as looked after children or LACs. So this young person had an escalated behaviour within their place of residence, and the police were called, which is very common. And the police then put this child onto a section 136. And a section 136 gives the police emergency powers because they feel at that time that that person may have a mental health disorder and require mental health review. And they need to move them from that public place to a place of safety to have a complete mental health assessment. So this is common for us that children are brought into our children's emergency department by the police on a section 136. When they then come through the department, they're then triaged. That's where we classify them, and then they'll be assessed while they're still on the 136 by our local mental health services, who will complete an assessment of them to decide what needs to happen next and what their plan is. So for this young person, the risk assessment was completed, and it showed that there was a risk, to themselves and to others. So due to this, the police then deemed that they were safe to be within the department, and they would have stepped down the 136. So then it's handed over to us to manage this young person's care. So in this situation, we would place them if on the risk, dependent on the risk assessment. But generally in this situation, for this young person, they'd be placed on a 2-to-1 for security staff. That means that we then have 2 security staff with 1 patient, 1 young person. They're then given a registered mental health nurse, which we bring in via agency, for 24/7 care within the children's ED department. The risk assessment for us is a decision-making tool. So this guides us to where this young person can be cared for and what their needs are. So this is we are guided within the Directorate of the Management of the Child on where to place them. So because they're a risk to themselves and to others, they would need to be in our children's ED department. Also included in that child's care is a nurse that's allocated from our children's ED department, and they maintain and support the holistic needs of the young person, focusing on their food, hygiene, care needs. And then we also engage with our play team, and I'll come into that a bit later about how they support them. Move on. So now looking at, if we on average are saying that this young person is going to stay with us for 6 days until a suitable placement is sourced. And so what we want to look at is the volume of time it takes for the young person, for us to care and manage the young person and ensure we're escalating appropriately. So what do we do? So initially when they come in, we'll be doing we complete daily escalation emails, and these are completed by the nurse in charge in ED or the matron, and they are sent out to our operational team, us as senior nurses, and our CAMS team. So everyone is aware that this young person is here and their needs while they're admitted and why they've been admitted. We then attend a daily ICB surge call. So this is a more recent addition, which is an escalation call. And in that call is our ICB colleagues, social care, and our mental health teams. So we can all ensure everyone's on the same path for this young person. We're all talking about the same things, and that stops silo working. It all means we're working together. We then need to attend initial meetings about this young person, and I put them professionals there that would need to be involved. And then following that, we go into daily escalation meetings with a wide range of professionals who are working in collaboration to move this child to the most suitable placement for them. And on average, we are calling our families every day. We're also liaising with social care, safeguarding, and other escalations. So on average, we estimate that within that amount of time, we're using approximately 144 hours of our clinical nursing time to be managing these young people within our department. Let's move on to the next. I just wanted to look at the impact that then has on us. So looking at our impact, why are we facing this? So we're facing this, as we know, and it's well known that there is a real reduction in the placements available. And this is because sometimes of the different risks that are associated with this young person, the needs of that young person in the community. We do have a pressure on us as a trust to move these children to a more suitable location. We understand that ED is not the best place for these young people. However, we also need to be mindful of the other children and families we have in our trust. And it's not always suitable to be moving them into a ward environment. And we also have to remember we're going into the ICB Search Hub. And now that that's really fully working, we have that collaborative approach together. So as we've just discussed, this is an unsuitable environment for the young person. They are being cared for by multiple professionals. It does have an impact on our team caring for this young person. We all come into the job as nurses to care for our children and young people. And I think it's really important to acknowledge the impact it has on the wellbeing of our nursing staff and our medical teams in the department when these young people are having regular behaviour escalations and there's a lot of other things going on within the department. Because these young people can have real volatile behaviours. We don't always know what's going to come next, and we are managing them 24/7 for that whole period of time. We need to understand the needs of that young person. They don't have a medical need, so they're not classified as a medical patient, but we need to ensure that our nursing team are giving that holistic approach to them. And we involve our play team, who are really heavily involved with our young people. We ensure that they are doing daily activities with them. We link in to see what kind of things they like when they're at home, making sure we're meeting their needs. And from a holistic approach, it's really important to ensure we're continuing to collaborate with all of our services because sometimes there is delays. There's delays in those processes. We don't all work the same. Thank you very much. So what's working really well for us? So we've got loads that's working really, really well. And I'm really proud to say that since we've merged as a directorate and moving forward, it's continuing to improve. The processes in place we have are working really well, and that's been reflected by the nursing and medical staff. We're really well supported by our operations team, and we can speak to them at any time if we've got any concerns and support with escalation. We work really closely with our local CAMS team to involve our interact assessments, and that risk assessment really does give us that basis of how we're going to care for that young person. We've got really clear documentation and pathways in place, which are continually developing and moving forward, which is really exciting for us. We are recognised, obviously, by NHS England that we need to be ensuring we have the right care for these young people with learning disability and autism in our areas, and that's something we're facing on a regular basis. And we have local level from our NEL BCYP team, who have just recently brought out a new report which looks at reducing the extended lengths of stay for young people. Also within our community, our Redbridge ICB have just designed a new pathway, looking at the integrated system of escalation, and that gives us a step-by-step approach of who needs to be involved in what days, at what time, to support escalation. We also have other things that are going on. So within the trust, we've now got a new youth worker project which is being run, and that's really exciting for us. That put youth workers in our ED departments, which will support looking after these young people and signposting. And we've got the development of our safe spaces, which is really exciting for us. Hopefully our first one will be going into our PAU area, which is just an amazing bespoke area for a young person who is on an admission to us to go and have an area of de-escalation and be cared for out of the ED department. So this is working really well for us. Other things just ongoing in the community is there's onwards work on pathways of support for us from different areas. And one of those is our MDT coordinator roles, which are going into the community. These are going into primary and secondary care. And these are going to help coordinate care to prevent families having to bring children to our ED. This hopefully will enable families to be signposted to the right support in the community, preventing them coming here in the first place. So challenges. So currently it is our space for our young people in ED. It's not a great environment. It's very noisy. It's very chaotic. There's often resus scenarios going on, and there's a lot of light, and it can be really, really overstimulating for a young person with autism. It is a lot of work for the team. As I showed in the previous slide, with the volume of time it takes for us to manage these young people, it falls on all of us, and it is a huge workload. And I really appreciate the work the team are doing around that, because they're working so well together, and it's a huge impact on them. It does take a long time to gain our placements, and it's very dependent on the young person. So sometimes we have a really on-board team who are working really closely and quickly to move these young people, but other times it can take a long time for that young person to be escalated through the system to then engage with the placement. And this only is a Monday to Friday service. So these young people, if they require a placement, will only be managed Monday to Friday by our external providers. We don't have a weekend service. So if we're getting towards the end of the week, that young person is potentially going to be here into the next week. And I think it's really important to highlight that the key worker role does enable us, would enable us to have an allocated person to manage these young people, which could potentially speed things up. It saves us swapping management every day, and we don't currently have that at the moment. So kind of bringing it all together, really, I hope this can reflect that we're really working hard to deliver holistic care and high quality care to our children and young people that come in. We understand that children's emergency department is not the right place for them to be, but we work to give them the best care we can while they're in our department. And we're really lucky that we're being involved internally and externally with the pathways that are being developed to just keep moving this forward and for the best for these young people.
Thank you. Thanks very much. Questions, comments? Will be loads there, Emily. Thank you for that. Matthew, do you want to?
I just want to start just by saying thank you to Emily and the team. They do a fantastic job at dealing with some really difficult, conflicting pressures, both in terms of the clinical care for these children, in supporting them working with their colleagues, and also, frankly, at times with people like me and other people asking a lot of them in terms of the management of these cases. It's a really difficult and demanding job, and they do it with huge skill and compassion. And then just thanks to Emily and a number of our colleagues who have joined the board for this section, and we do recognise the fantastic contribution to making extremely tough circumstances. Thank you.
Okay. No, thank you for that, Matthew. And you speak on behalf of all of us, and I can see some nods on colleagues on the call. So re-emphasise the comments that Matthew has made. It's a very tough slog out there, day in, day out. So really appreciate that as a board. I've got Leslie and then Caroline, I think. Perhaps anyone else, I'm not sure, but over to you folks first.
Yeah, so thank you very much. And that's a really helpful explanation. And I question this at most board meetings, Norway from local authority chief exec process, I think. But my background has been working in local authority, so I've kind of seen it from both sides. And it is incredibly difficult because, as you say, this is absolutely not the right place for vulnerable young people. And I think it's been about a year ago, I think, doing one of our exhibits. I was with Mampta in Children's ED, and we saw somebody, and I came back outraged. And had said to Matthew, you just need to get on the phone to the chief executive of whichever local authority is responsible. So I think you're doing an amazing job, but it's not necessarily a job you should be doing because you're not social workers and you're not trained to be social workers, and you've got other young people who have a medical need, which is exactly what you're trained to be dealing with. So I suppose I wondered, does the ICB pathway now, and I wanted you to say, is that leading to any improvement? But also you talked about Redbridge Council having a pathway with you. How are the relationships with Barking and Dagenham and Havering councils? Because at the end of the day, they are the ones that need to find a place. And I know from their perspective, it's really difficult because their budgets are hugely overspent. And since private finance, private capital got involved in running children's homes, they are ludicrously expensive. You could probably send one of the people you've got in A&E to Eton for a year and it'll be cheaper than a care placement, which is all wrong. So I know there are difficulties, but it's not working for the young person, never mind not working for the staff. We are not helping. We are all collectively failing young people. So it's really just a little bit about your relationships with the local authorities. And do you see any movement happening that way?
Do you want me to?
Yeah.
I'll just take Caroline and then bring you in, and then you can answer the questions. And Caroline, do you want to make your point?
Partly building on Leslie's question there with the ICB, seems that you're doing an awful lot of the legwork with the meetings and the admin and all of that. Is there an opportunity for the ICB and other partners to take on more of that? And also on a practical basis, whilst we start with the situation, is there a way of repurposing any part of children's ED that you do have dimmable lights, you do have screens, you may be able to have some noise cancelling headphones or something like that, just simply to make people's lives easier whilst we're in the situation?
I'll just bring Fiona in and then pass over
Yeah.
to you.
Just before Emily talks about her individual, I just wanted to sort of set the scene a little bit around the different boroughs and different responses, because I think every case is unique. I think every child that has attended has presented a different set of circumstances, that some of which are around money, some of which are around coordination, and some of which are around whose responsibility. And I think what we've learned is what we're not very good at, as opposed to what we've not particularly got better at doing this, because this is a multi-agency, quite complex discussion with children who have complex backgrounds, and so we're not just negotiating with one agency. And I think we've certainly, as a collective, really improved how we talk about these cases together. I think everybody's learned a lot about how not to do some of this, and I think a lot of it is to do with maybe some failures previous to attendances that could have been better managed in other community settings. So I'm sorry to jump in, but I wanted to take it away from being like what is a borough like, more to that kind of multi-agency. And I think it was really the last child that we had in was the complexity of negotiation and discussion was huge. And the one thing that Emily, I must say, just to go back to what Matthew said, but we do take on, rightly or wrongly, a negotiating responsibility for these children. We have a coordinating role and a bringing together. And I think because they're so complex, because they're all unique, I don't think there will ever be a scenario where one agency takes a lead role and negotiates everything for everybody. So I think we'll have to continue to bespoke these with everyone who offers support and guidance and expertise. But again, as we know, we do have a coordinating role, and we will probably continue to do that.
Yeah, and that advocacy role that we take on, the commitment for you guys and the team doing that and fighting to get the best for those young people. But my comment really is about how we can go upstream, working with vertical integration with our partners more on this, because ED is the last place where we want to have these young people turn. But perhaps Emily and Beth, you want to respond to some of the comments you've heard.
Absolutely, I'm happy to feed back So from the pathway perspective, I think there has been so many improvements, and it's definitely going the right direction. The new pathway from Redbridge is just gives such a clear approach, and I would hope then that is reflected across. So currently we go into our IC surge meeting, and the relevant teams are in there, and then we are confident that the right people are engaged. Sometimes it can go up really quick, and sometimes it's very dependent on who's there. So I am confident that the pathways are improving and can only get stronger. And I think with the NEL BCYP partnership that I shared with their most recent document, that highlights the need for us within NEL. So it's a NEL wide approach to this system working. And the new areas, I do agree. I think it's really important to have the areas, the farmer areas in the ED department. And we're really working on where we place these young people when they are here and making sure we've got the best areas for them. The new addition of the safe space, hopefully when that comes early next year, will be the area that, although we're aware it's only one, but this is a starting process, and this just shows that we really are looking at these bespoke models to move these young people to different areas so that they can de-escalate, because actually if they do de-escalate, the hope then is we won't need all these intense people, we won't need all the security and everybody. We can just have one person caring for them, and that hopefully will then help them calm a lot better and give them a better level of care.
Thank you. Thanks very much for that. I was just thinking that this has been really helpful, but we need to consider what you've said and think through up to 2 or 3 actions that as a board we can do. There's a lot that you're doing, there's a lot that Fiona and others doing as well. Matthew, do you want to have some comments?
Sure, there's a few things. I mean, lots of, as Fiona and Emily and others have said, the route out of this is via partnership working, and some of it's about partners taking more explicit responsibility. At times it's not always clear who should be in that position, and actually some of these cases, the longest cases, tend to be incredibly complicated in terms of who is the kind of corporate parent versus the role that parents themselves play in this, court protection, etc. So some of them are really quite complicated now. So this is all about getting the best possible relationship with their partners. The capital investment in the right spaces is important too. I know we've previously talked about 1 or 2 of these cases at board, and I've seen people externally saying, well, why didn't they put them on the children's ward? There is a duty of care to these children. There's also a duty of care to the asthmatic 4-year-olds and the 11-year-olds who's just had their appendix out, not to be in a room next to a 15-year-old who's turning the air blue and trying to kick a hole through the wall. You know, and now I'll speak quite crudely about that because I think the team are probably too compassionate to put it in quite that light. But, you know, there are children and there are children. They all deserve to be treated as children and looked after. There is a significant difference between a physically aggressive 15-year-old who's taller than me and a physically unwell child and their parents who've come in for a different kind of procedure. And what we're trying to do here constantly is balance out all these different risks. When children are in A&E for a prolonged period of time, the risk assessments are ongoing and they're done with plenty of input from psychological support, psychiatry and others as well. And we try to find the right balance between recognising they're in the wrong place full stop. How do we manage that in the context of those patients and others as well? So I think the capital investment will help with that. There will always be cases where we haven't got enough room. We'll just have to work with that. I think the best thing we can do is to continue to support Emily and the team, because they're, as with so many of our teams actually, particularly in the emergency department and in the adult and children's pathways, they become expert at things that they never really imagined they'd have to become expert at. And yet, as we'll hear about mental health in ED, we've had to become expert at delivering crisis mental health care for adults as well as for children. All kinds of challenging behaviour we're dealing with, so they need our ongoing help and support. And I think the recognition for a job that is often quite thankless but tremendously well done under superb leadership as well. Thank you.
Thank you. Thanks, Matthew. And I think we've got some actions there that we will. So you've been really good hearing from yourself, and also seeing the sort of comments that have come from board colleagues. So thank you for coming along there. But I think we could follow some of this up in 6 months' time through Quality Assurance Committee. I'm looking to Hilary there to see if we can put an agenda item on that.
Yeah, thank you very much.
Yeah, thank you. Keep up with brilliant work.
Thank you.
Moving on to the next item on the agenda, board declarations of interest. I think everyone's out there. Hillary's has been updated as a member of the management team at PA Consulting. And online, we have, I should actually mention it because I can't get onto the Teams chat. So welcome to Lorraine Silver from the chair of Health Watch Redbridge joining online. Next item, we're minutes of the previous meeting. We've got the 5th of September, and then we had the extraordinary meeting on the 17th of October. Is there anything on the minutes of the 5th of September that colleagues want to raise? Any corrections? Sue?
It's a tiny point. Under 7.2.2, it says that Leslie and Ruth have joined it as attendees. I think they've joined as members, haven't they?
They have.
They have joined as members.
Yeah, so if we could just amend that.
Thank you for that.
Did wonder whether that meant it was discretionary.
Yeah. You have to attend. It's not.
Did you have a vote in reward?
Yes. And then we've got the minutes of the 17th of October, extraordinary meeting, and we're happy to approve those as a correct record. Thank you. I've not got any matters arising identified to me, but that doesn't prevent you from raising any matters arising. No. Excellent. Thank you. Action tracker. Linda, do you want to update us on that, please?
Yeah, so we've got two actions that we're proposing closed. One relating to the Digital Advisory Board and the second relating to an update on gynecology PTM that have been taken in the Part 2 section of the meeting. We've got an action that's open relating to board seminar scheduling. Now we've got a large number of items on the list, so we've got to do some prioritisation and see if we can find maybe some more time for some of these items and how we place them. And then finally, we've got one action that's proposed that we bring to the board in January if Gillian is in agreement following its receipt of the people committee in relation to the social safety staff.
Okay, thank you, Linda. Any questions from colleagues? Not, we'll move on to item 8, Trust Board membership. It's written as printed, and I just want to highlight a couple of things on there. First of all, for on record, the huge thanks to Shane DeGaris for the service that he's given us as accountable officer, and also Matthew worked very hard as deputy chief exec over at the Barts Health Group. So Matthew, glad to have you back with us fully. On Shane's change on that, it doesn't change the approach, our other values or our drive to be, collaborative, strong partners, both vertical and horizontal, but particularly on the horizontal element, our collaboration with Barts on delivering our digital program will remain as strong as ever. But we had conversations numerous times since I became acting chair with colleagues at Barts and Homerton that reaffirms our commitment to making the APC a successful vehicle for collaboration going forward. And that commitment, something that this change of accountable officer does have no impact on that at all whatsoever. And the three trusts are aligned on the joint vision, their approach towards that. So today is Mamta's last day as board member, but I'll save any comments until the end of the meeting, so that we can say what we would like to say.
That's exactly what he said to me.
But welcome, welcome Andrew joining the board as our interim CMO. So congratulations on that, Andrew. Are there any comments on this change of trust board membership? Go on to item 9, chair's report. Yes, I'll try and keep this brief because I don't want us to run over just at the start of the meeting. But for me, we had a really good visit by Wes Street in the Secretary of State for Health and Social Care to King George Hospital, where he met some who were previously very vulnerable young people with learning disabilities and autism who, under other circumstances, would not have found a vocation. And to hear them speak, you know, very confidently about how their lives have been transformed by our trust being involved in Operation Search was really, really important. And you could see from the cohort that was available there, the transformation their experts had on them as individuals. Well, and Wes came to see that and met with the organisation who we partnered with. And I'm sure that's part of his visit was to see how he can spread this best practice in his role with the NHS as a national employer. At the last meeting, you might have heard me mention that our ED department at Queen's takes on twice as many patients as it was built for. Matthew and I have been doing our best to influence others that we do need around £35 million worth of investment in that to expand it. It's not those of you, and I'm sure every board member's been down there, you know, knows that this is an issue that of huge priority for us because of the just the circumstances in which those people, our residents, our patients, have to endure. And talking about ED, it's been a constant issue for us. And as good system partners, we're looking at how we can have an urgent care mental health pathway across the system and collaborating with others. And but the circumstances were 347 patients who could have been referred to mental health services were in ED in September, 154 at Queen's, still significantly higher at King George Hospital at 193, and the average. So this is the average stay was over 23 hours. I think Matthew might want to say something further about that, about what we're doing with our partners. On a positive, I represented our trust at a meeting with the Alan Turing Institute, and I'm going to ask them to come along to a future meeting, a seminar session, to talk about how AI is currently being used to transform health and social care, but the future opportunities, the potential of it, not just in analysing and assessing large amounts of data and helping clinicians in that respect or taking notes in meetings, but actually carrying out carrying out tasks that would otherwise have been carried out by staff, so freeing up staff to be able to, you know, add that added value care of patients. It's mind-blowing in some ways to see what the future holds for health and social care. When you look globally at the advances in places like America and South Korea, you can see that, you know, why, on my last comment, is why they've got it in the NHS 10-year plan as something that we need to catch up on. And my last thing is to say, please do respond to the consultation on the NHS plan. Unfortunately, Matthew and I, we've had a look. We don't have any room for a Wetherspoons at Queen George. But we did ensure that there was Aldi across the road, which meets the needs of many of our staff and patients. But seriously, do contribute to that, because this is going to be an important piece of our work going forward. Matthew, I'll sort of seamlessly, and then we'll take any questions, any comments.
Thank you very much, Chair. Right, so there's quite a lot in my update this month, so I'll pick a few highlights out. I would recommend that you do take the time to read our new organisational strategy. I hope as NHS organisational strategy goes, it makes a great deal of sense and is very practical, because that's what we're aiming for. I think the thing in there that says our purpose as an organisation is we want our hospitals to deliver care we're proud of and that our patients are happy with. And there's plenty in there that's worth having a look at that explains how to go about that. I think what we've had in the last month is a really sobering example of where we got that wrong, and that was the inquest into the case of Chloe Every. There was a young woman with learning disabilities who we failed in a number of instances in terms of care we provided for her. I think that was something that has been widely scrutinised and shared within the organisation, and it's a sobering reminder of how important it is to make sure that we listen to the family in cases such as this. And I've apologised for this previously, and would repeat again how sorry we are for the mistakes we made. I just want to say thanks to Mamta for the work she's done with the Every family around this, and to everyone involved in learning disability care within the trust. In respect to the improvements we've made over the last few years to try to reduce the repeat of that. But it's important that we recognise when we get things wrong, that we discuss those cases, and that we learn from the only way to try to avoid repeat. We're spending a lot of time looking at the money. At the minute, you'll have an update from Mike later, but halfway through the year, we're around £10 million overspent. Our run rate has been improving in the second quarter of the year, and we've got plans in place that we hope will get closer back to plan later on in the year. But we're in for, I think, a fairly tough period of time ahead. We're under this triple lock process, so any expenditure over £50,000 needs multiple levels of approval, and that does significantly constrain our ability to invest in service changes, in new service and new posts, etc. So it's in our interests to get out of that as soon as possible. Part of that's been the use of high-cost agency nurses, which we're now bringing to an end. And I'm delighted that we've got 130 newly qualified UK nurses joining us by the end of December. I think that's after a number of years where we've done lots of overseas recruitment, but we're really keen as a local employer to make sure that we offer routes into nursing and all kinds of different roles within the NHS through the trust. So it's great to see those newly qualified nurses, many of whom have trained here, coming on board, and that'll help us with our cost base as well as improving the quality of our care. Another big area of mental health spend, you've heard quite a lot about that this morning. We spent more than £6 million last year, specifically on mental health care, which actually dwarfs the amount of money we spend on people in emergency department corridors. That's a more visible manifestation of the pressures we're under, but if you look in the financial report, you can see what that's costing us. Probably what the single biggest risk we're carrying at the minute in our emergency departments is that we're effectively running crisis mental health care now to North East London. To a large extent, King George Hospital is the biggest receiver of Section 136 patients in North East London, and actually is the single biggest acute trust receiver of Section 136 patients in the whole of London. My previous job at Oxley is we had a dedicated mental health hospital that saw fewer Section 136 patients than we see through the emergency department at King George. That is a huge, it's a huge issue around quality, around safety, around capacity. And I think at times, as it says in my report, we've had days where you walk into that emergency department and it feels more like a security-driven environment than a healthcare environment, because of the number of police and security guards we have in there to keep the mental health patients safe and to keep other patients safe. And it's a very, very challenging and very difficult place. That's something that has progressively got worse every year I've been here, and we're expecting a notable shift in that over the course of this winter. So I think it's worth drawing attention to that. That does impact our performance. We're still doing relatively well, but we are seeing record attendances. October, we saw 17% more than the previous year across our trusts. It was one of our busiest ever months for Type 1 attendances. We're also seeing a huge increase in ambulances coming in September and October. 669 more ambulances just came to Queen's, 84 extra ambulances a week to Queen's. Only 1 in 6 of those patients actually needed admission to hospital. So we've seen a real surge actually in the number of ambulance cases brought in, and that pressure on the front door means that this winter, knowing that there's no extra money coming down the tracks as usually, means our real issue this winter is reducing harm and ED to patients who will be waiting in some cases a very long time for the care that they need, and also reducing the harm to staff from working in some extremely pressured and challenging environments. And I think that feels like a bit of a step change from last winter in terms of where we need to focus our efforts to try to maintain safety as best as we can. Finally, some good progress on waiting lists. We've halved the 52-week waiters. Without the strikes, we've been able to really crack into that. We're down to about 1,100 now. Fiona will say more later. Women are still facing the longest waits, generally on our gynae pathway. Great example of how we're trying to tackle that is the Women's Health Hub. We're opening in the Ilford Exchange Shopping Centre, offering things like Urogynae support and menopause clinics. And that kind of innovation is going to be key to helping with those waiting lists. Some good information on there on great progress in cancer, including the Barking Community Diagnostic Centre. And finally, just a heads up that CQC inspected our maternity department as part of their national programme of inspections. No immediate enforcement actions, but quite a lot in there that we do have to keep a focus on, as this board's had plenty about in recent months. We're expecting the report sometime next year. Thank you.
Yeah, thank you very much, Matthew. There's certainly a lot going on there. And any contributions from board colleagues, Leslie and Hilary?
It was on yours really, and just mindful of both in the BART board meeting and the APC board meeting, there's been a conversation on AI and the use of AI and about talking to UCH partners and the Alan Turing Institute. And I was just a bit conscious that we might be in danger of having the same people having the same discussions 3 separate times in East London, and we talked previously about perhaps having some joint board meetings with the Homerton and BARTs, and that might be a really interesting and useful topic for one of those joint meetings where we have all the best people come and talk to us all once rather than come and talk to us all separately.
Right. Yeah, no, thanks, Leslie. Definitely. Really good.
It was more an observation. I wasn't here for the last board, but I noticed from the minutes, I think it's item 18.4, about the high proportion of disabled staff who feel that they are harassed, bullied, not treated as well as they might be. And I was thinking about the intersection of that with learning disabilities as well, just in terms of education, because it may well be that staff don't appreciate that's how a disabled person feels. It's a cultural thing sometimes just as much as a genuine thing. Just that observation, really.
No, thanks, Hilary, on that. Indeed. I mean, one of the facts that sticks into my mind was during the pandemic, the number of very high proportion of people with learning disabilities who actually passed away from COVID, and how things have changed since then. But every death is a sad death, and the Chloe's in particular was something that's, if you look at it, and huge thanks to Mamta for her and other colleagues for their involvement. It is, you can see Webb's parents, family have been hugely affected by it, and more should have been done for Chloe. Yeah. And as Matthew has said, the organisation has learned from there. And so the issue that you've raised there, I'm sure we can get Janine and Leslie to look at that as part of their role. Yeah. Okay, so thank you for that. As always, conscious of time. Item 11, digital update. Over to you, David. And David, if you want to pick up on Leslie's point, please, about 3 boards or 5 boards coming together, talk about things in common.
Yeah, sure. So just to pick up on the EPR and especially the impact of AI, I think recently, in fact last week, Oracle Health released their own foray into the AI world, which was quite revolutionary. And I think statistically they're reporting that it will see a reduction in the need to actually use the EPR, i.e. type into the EPR by up to 50% for clinicians, which is a significant improvement. So I think one of the key things, particularly for collaborative working across the APC, is to make sure that we do work together, particularly with our partners, with Oracle Health as our main EPR provider, to look at what they do, so that we've got a joined up approach, particularly with regards to clinical safety cases, and ensuring that any AI that we use as an organisation is ethically implemented. So I think that's more one key point. Just turning more broadly to the digital update, we're continuing to look to improve the service, and part of one of those initiatives is that we've joined the Service Desk Institute, which enables us to evaluate the service that we offer our staff against other industry benchmarks, and there's some interesting information coming out of that work, which is allowing us to focus on areas to improve. But predominantly, as we modernise our technical infrastructure, the ability to be able to drive more and more support type calls to the self-service model will become more apparent. I think that's essential as the footprint of digital services grows within the trust, and the systems that we use in trust grows. But obviously we need to constrain the cost pressures that we have through the amount of staff that we need to use to support that. So we really do have to work smart, not hard, I think is my favourite saying, and continue to look at that digital front door for staff. We're continuing to improve our infrastructure, and that includes our network rollout, which continues to aim to deliver by the end of January next year. Cognizant that we have to do that because we continue to see suboptimal performance in our local network and infrastructure, and that is an area where the investment, I think, will pay dividends. Alongside that, we continue to monitor our cybersecurity posture, and we continue to look for threat actors which, given the political climate of the world at the moment, the NHS continues and remains a very high-risk target. So we're continuing to monitor that. I'm pleased to say that the measures that we have in place continue to protect the trust, and the trust has not been at risk, despite the fact that we do identify new and varied threats. Moving on to the electronic patient record. So we're continuing to move along to a projected go-live date of June 2025. And we're now in the testing phase and the data migration phase. There are a number of risks associated with that, as you'd expect in any EPR programme, and these change from week to week based on the progress that we make and also things that we find as we progress through the programme. At the moment, we're continuing to remain on track for that June go-live date, but we do go through a number of gateway reviews to make sure that the system that we're intending to implement is safe and is correctly built for the trust. And we're working with our partners and colleagues at Barts Health to progress with the programme. Finally, I suppose more importantly around the information governance component of the report, we're continuing to eat into the backlog of freedom of information requests. So just as a reminder, the trust had built up a significant backlog of over 600 requests at the beginning of the year on account of a number of factors. We've now got a fully staffed team, which is now eating into that, and as of the last report, that was around 300 mark, with the aim to clear those all off by Christmas as per the commitment of the ICO. But we still do face challenges around subject access requests, and there have been a number of complaints over the past month. This is predominantly driven by an understaffing within the department, which has now been addressed. So I'm pleased to say that subject access request teams now fully staffed. But we do have a significant backlog in that area, and it's not really helped by the fact that because we're paper-based, doing a subject access request does involve trawling paper as well as disparate electronic systems that we have across the organisation. So what should be a relatively straightforward activity for an organisation that's fully digital means that for our organisation it's a real onerous task, and I think that is an area where we are going to have to look at overstaffing in order to try to reduce that backlog in a reasonable timescale. So that concludes my report, Chair.
Yeah, thank you very much, Sue and Caroline.
Thank you. Thanks for the summary report, David, and it's good to hear that we are absolutely moving in the right direction, but we've got a lot of work to do. On the subject of FOIs and SARS, as we go along, are we being agile around the things that we discover that we're having to report on, particularly around FOIs, and creating space on our website so that we're putting that information up so that FOI doesn't come again? Are we able to do that as part of this process?
Yes, we are doing that as part of the process.
Perfect.
So we are updating the website.
Thank you.
Caroline?
Staying on that subject, thinking about the subject access requests, are there themes that are coming through? And what I'm thinking is, if there are, are people contacting about particular themes or subjects where they could be addressed further upstream, perhaps?
I think it's fair to say, because we've not had the staffing in place, we've not really done the thematic analysis. From the the complaints I've received, which aren't a representative sample, but sort of anecdotally, it's certainly reflective of requiring medical records in order to assess the care that's being delivered or the accuracy of the information that's being recorded about the care that's given. So again, I think that whilst we remain in this paper world that we live in, it's difficult for staff, whether at the front end of the process or whether in the subject access team, to really be able to respond well to SARS. I think this will be something that we'll continue to really struggle with until we're fully digital. So we're expecting it to improve. Obviously, I'm expecting the backlog to improve, but I do think we're going to have to put some concerted effort in, the staffing of the team to reduce it at a faster rate.
Thank you, David. That we've got this item later on in part 2 as well, so we'll pick up some points then too. So moving on to Quality Assurance Committee chairs, or over to you, Hilary.
Thank you, Chair. There's not a lot to mention here. I think the minutes speak for themselves, but perhaps say a little bit about some of the areas where we didn't get significant assurance, as it were, and we had partial assurance. So the first of those, the integrated item 3.1. I think really the important point there is that where there have been areas of low compliance, they will now be included in the next integrated quality and safety report. Sepsis 6 was one that stood out, I have to say, on the visit that we just did to Clementine B. There was a very nice poster up showing Sepsis 6 and explaining it for staff to use. So it was a nice positive thing, given that had been flagged as an area where we don't always perform as we should. PSERF, I think, is work in progress and is going to come back to the committee on a quarterly basis as we see that kind of cultural transition from the serious incident framework to patient safety incident, which I think is a very positive step, but it just takes people some time to get used to it and embed it. Learning from deaths, there are a couple of items here that are picked up sort of as sub-items on the report anyway, but I think perhaps the important point there is where we've been doing deep dives, such as the aspiration pneumonias, and learning from both through patients who potentially died, but also from this being picked up in quality and safety in relation to people who perhaps were near deaths rather than actual deaths. The other areas, and it sort of ties in with updating the terms of reference, which we'll get to. But I think the other areas were really the award accreditation framework gets a mention. I really had a great hour with Lucy recently going through and then saw in evidence as I went around the hospital with Fiona and Russ, how people are really proud of it and how it's making a real difference. And again, it was mentioned on on Clementine B this morning. People are very aware of where they're at and what they need to do to get better. And I think that kind of healthy competition is actually driving standards up. So it's something I think to be treasured, really. And there seem to be relatively few trusts in London that are adopting it and perhaps being as innovative as BHR, which is great news. I'm going to hand over to perhaps Beth to talk about it. Well, the next item is actually the sub-item is yours, Mamta. I don't know anything you wanted to say about that.
The Caldecott Guardian, that's the annual report. So we have, it's actually just for information or for assurance to the board around the incidents and the actions we've taken around that. So there haven't been any major breaches during 23-24. A significant conversation was had between Matthew, myself, and the Caldecott Guardian around the destruction of the notes or the records that we had before 2006, and we hadn't accessed it for a good 8-10 years. So made a decision to destroy those notes with approval of the IGSG. Other than that, we've had incidents that we've reported 6 incidents to the ICO, but actually they were closed with no further action to be taken, and we've been monitoring our incidents within the organisation. That's it from me, Chair.
Thank you, Beth, on the CQC surveys. I think the thing that struck me was the difference in the sample, relatively small sample for the inpatient as compared with the cancer.
Yeah.
So thank you. So yes, the survey was sent out to patients over 16 who have a length of stay over 24 hours during November last year. The results were published in August 24, and as mentioned, the sample size actually equates to 0.3% of the inpatients that actually stayed with us during that year. So the response rate was slightly lower than the previous year, with only 317 responders. So I guess in terms of what we learned from the survey, so from the 11 sections in the survey compared to last year, the trust scored worse in one section, somewhat worse in 3 sections, and about the same in 6 sections. And actually you can see the detail of that throughout the report and the various questions as well. Just in terms of assurance about other patient feedback we get, one, because of the small sample size, but we also have routes of patient feedback throughout the year. So we have our friends and family test, and about 88% of patients describe a positive experience. We also have a regular survey for dementia and learning disability patients and carers, and we have positive experience feedback from that as well. Our patient experience facilitators speak daily to patients across the wards in the areas. And since last year, we've had patient panels that have been running, which have been proven to be hugely helpful in terms of hearing directly from patients and their families. And our patient partners are actively involved in the ward accreditation framework. So that is also a really kind of live element of our feedback. So next steps for this survey: patient experience team have met with all of the clinical groups and an action plan is in progress. That is planned to go to the patient experience group in January. As I said, the facilitators are on the wards continually getting feedback. We also send SMS discharge text alerts. It's sort of like a wellbeing text to see how people are doing. And there's some work being done to promote this year's survey, which starts this month, so that we can gain further feedback.
And then back to Mamta on the learning from deaths for Q1.
Yeah, so this is the Q1 report for learning from death. We have made a significant change to how we do mortality management within the organisation, with a new SOP that includes the statutory medical examiner into the conversations or into the structured judgment reviews that we do. So if the medical examiners are concerned about the care that we have delivered, it is independent of us and they will speak to the coroner, but we have enlisted that those deaths would be discussed or will have a deep dive from the mortality team. And I think that is assurance in terms of the learning that we need to do in a proactive manner. I'd just like to touch upon the, we were an outlier with relation to deaths related to aspiration pneumonia. And this often can happen if it is related to poor nursing care or poor care in hospital. And we've done a deep dive into the 12 deaths that we looked at, in which we found that the care was, for more than 10 patients, the care was good or as expected. And in 2 of them, we could have probably done something differently in the first 24 hours of being in hospital. In addition, so then the detailed report talks about the number of deaths we've had within the organisation, and a little bit more detail around the aspiration pneumonitis deep dive. When Kathy McLean was here, we talked about the increased mortality, or whether we were able to demonstrate increased mortality related to the length of stay of patients in ED. We've demonstrated there isn't an increased mortality, but what I think we probably needed to do was, and we spoke at QAC, was to look at whether a length of stay in the corridors increases the morbidity or increases the length of stay of the patients within the hospital. And it's a little bit more trickier to pick up, to have a direct correlation for one for the other, but the patient safety team are trying or attempting to look at that information and see if we're able to learn anything through that. So that's the update for that.
Thank you. And I think finally, the integrated quality and safety report.
Thank you. Looking at all my papers, right. So in terms of I'm just going to pick up the highlights from the integrated quality and safety report. So we had concerns about the number of incidents we were reporting. So we've now shown an upward trend in the number of incidents that we are reporting on a daily basis within the organization. And the key themes around our incidents appear to be related to clinical care, which is predominantly communication with families or with patients, and workforce incidents. We've not had any never events for the month of September, which I think is really good. And we've also done really well with our duty of candor. We were struggling with getting the duty of candor on time, as well as the quality of the letters that we were sending out. So we worked with our patient partners and have shown a significant improvement in our duty of candor. We've our VTE assessment, we struggled with in the previous month, partly because we changed the way we were reporting data, where every patient that was admitted or in hospital was expected to have VTE assessment, and it was inappropriate where they were in day cases or where they were coming in for short periods of time. We received one PFT in September. We've had another one for the month of October, which we'll discuss next board, and that was related to a patient which was under the care of multiple specialties, and we could have done things differently to provide better care. I'm not sure that we would have prevented the death of the gentleman. In terms of complaints, we seem to be doing better with complaints, and the PALS response is also much better. It's much better than it has been. The huge feedback from Andrew and the team from King George's having face-to-face PALS at the front door, which I think has probably helped with better communication. We've had, I'm just going to touch a little bit about well-led, partly because we will talk about it in the CQC for maternity, is the number of overdue risks that we have and the overdue risk actions that we're trying to work through. So we went through a fantastic blitz of getting it down, but we're back up again. With particular mention would be around the mandatory training compliance and the effort that we've made to improve that mandatory training compliance. And we had a fantastic paper discussion yesterday at Tech in terms of the actions we will be taking as an organization to help through that. So I'm happy to take any questions.
Thank you very much for the suite of reports. Leslie
Um,
and Caroline.
I've got a couple of questions. One is, it's sort of a general question because there was a few reports that actually related to patient feedback. And you mentioned that we also do patient panels and friends of family and things like that. The CQC one was very heavily skewed towards over 80% of responders were people over 50. So I suppose one of my questions is a general question about, in all the other stuff we do, are we making sure that we actually do get a balanced response? It was quite a white response, wasn't it?
Yeah.
So
And we make a tiny percentage of our activity.
exactly. So in all the stuff we do, are we sure that what we're getting is a picture that actually truly reflects the demographics and the age of people that come to us? And then a couple of questions on the integrated performance report. It's really good to see both actually on duty of candor and on complaint that we, at least quantitatively, we're responding in time. And in a way, although there's still qualitative issues, you can focus on those ones you know you're actually getting them all done in time the next step is to make sure that they don't sound as though they were machine and not doctor written and not written in human speak. And then the issue around overdue risk reviews and actions, it's one of our favourite topics, so isn't it? At audit committee, do and I play a game? Can we find the most absurd risk on the risk register? So I think some of the work that is inevitably going to happen post the review that we had of risk is perhaps going to mean that we reduce some of those risks down and we put things that are genuinely not risks, not the door is open or things like that, which are the sorts of things that we have been putting down as risk. And then my final thing is that the page 28 or 109, depending on which you're looking at, which was the Ulysses system risk. And that kind of didn't sound, I didn't understand all the detail of it, but it didn't sound very good to me. And I wondered if that was, that seems to me the sort of thing where you'd want audit to just go and have a look at it, because it seemed to me, reading what I read here, I kind of went, oh, I don't think that doesn't sound right to me. And is that the kind of thing where actually somebody, independently in terms of an audit, just going in and looking at it might come up with some things that we need to do? So they were my questions.
I'm happy to take. So
Sue might have similar
So we
questions.
should do a round.
Okay,
I think
yeah,
there's only one turn colleagues. There's only Caroline and Sue who have indicated, and the things that I had on my list have been ticked off. So Caroline.
Thank you very much for the reports. I'm always really heartened where you're taking some interesting measures like the corridor care and see where there'll be an implication elsewhere. I always think there's quite a lot of detective work. We're looking at clues and the impact of, not everyone's done the Oliver McGowan training, but in your area where they have done it, it's going to really reap dividends. One of the things I was noticing was there's a thing in the report around the timeliness and communication. So both in terms of people saying they haven't had the information when they came in, but also around the translation services as well. And I wondered if you might be able to say a little bit more about that, because it almost looks like an area that merits some investigation in itself as to how the joined up approach around communication would be improved. And so, and therefore save problems further downstream.
Yeah. I mean, I have to say we haven't looked at translation services particularly, but
I'm going to just get
sorry,
Sue's
point.
comment in, and then
So Leslie's quite right. She stole two of my items because we both just feel and think the same. Absolutely. And I was particularly concerned about the apparent lack of mitigation around that Ulysses issue and what the consequences of that could be. It wasn't clear to me what the real consequences might be of us not being able to resolve that. I also had a similar question about the 130 tags requiring an assessment, and if we don't sort that out, we might not be funded under payment by results. So I'd like to understand what we're doing to address that. And then a slightly more general point. I found some of these reports, in particular the Learning from Deaths report, quite hard to understand because we're getting more and more acronym heavy. And I just wonder whether either we need a glossary or we need to write these in slightly more common parlance so that any member of the public reading these would actually understand what's happening. But my biggest points were the points that Leslie raised around risk and resourcing and mitigations. Thank you.
thank you for that. And so I get to go last, and all my stuff almost gets ticked off. But just to say that on the demographic profile of those completing the adult inpatient survey, people of colour seem to be very low in terms of representation on there, and it's in a lot of trusts. But perhaps you don't have to comment now, but as we think through what we can do with partners to try and up those numbers on there. And in terms of dealing with complaints, the front office locations have been working really well. So I'm really pleased about those on there. And my final comment was on the number of overdue risk actions creeping up. I've been in a place before here whereby it creeps up and then it just keeps on going up. So it's getting them back down. It takes a mammoth task because you're dealing with things that are becoming overdue quite rapidly. And so it'd be useful to get your comments on what sort of capacity we've got and focus on those, please. But it's been, we received some really good reports. Acronyms, yes, need to be dealt with. However, the insight that you get from having these 3 reports together presented by the chair is always helpful. So, Hilary, do you want to coordinate?
I'll go first, but I think most of the answers have come from my colleagues. On the survey, given it's such a tiny, 0.3% of activity, it is so unrepresentative in so many respects that I was wondering if the CQC would be up for a conversation about actually, do we not triangulate all the ways in which we get feedback, some of which might be verbal at the front desk in terms of the timeliness within which we deal with complaints or concerns or whatever, and also taking all of those other sources like the family and friends test, not just relying on a survey that is posted out by the CQC, which is not very well responded to. I think there were no responses under 45, isn't that right? So it's just not fit for purpose, I think, as a way of assessing our performance. With the new leader coming into the CQC, I wonder if that's something he'd be up for a conversation with. I saw him on Tuesday and I believe he's seen you. Oh, he's hoping to see you. Yeah. Given you used to work there. So I think that's really helpful. I've been thinking about a glossary for a long time, Sue. I think it would be, even as a medic, I have to go away and look stuff up because I haven't been in clinical practice since 2007 and things have changed. And I don't think if I'm having to look things up, then I've got to think what other people's positions. So, you write it out in full the first time you use it in the paper, and then, but also you then give people a glossary. And once they get used to using the glossary, you may not have to write it out in full, but I think that would be an important thing. But I will hand over on the questions of Ulysses and the other translation services. One comment on that, my public health daughter said to me the other day that areas of greatest deprivation have the largest number of languages to deal with, but nobody pays for translation services over and above the standard sort of tariff. And yet actually the cost of translation services to give people a better experience and get there faster should probably be factored in, which wasn't a thought I'd had before, but anyway.
So I'll start with the patient experience. So Hilary, I totally agree with you in terms of the sample size, and I think that's why it's so important the work that we do internally. I believe we do gain feedback from across all ages, but I will ask Abby to verify that for us, and we can maybe bring that out in the next PEG report that comes to QAC. In terms of the cancer patient experience survey, absolutely. I mean, the response was not reflective of our population at all. And that includes age and sex as well. So the team, in terms of the work, they're putting in a plan to make sure that they get responses for the next survey. So they will actively have a plan in place to encourage people and promote the survey. The other thing in the cancer experience survey, it picked up certain tumour groups responded more than others, and again that's quite interesting because there could again be a demographic and age sex issue on that. Do you want me to talk about the risk actions?
Yeah, go on. I'll sum up the rest.
So in terms of the overdue risk actions, so Kerry has actually started risk clinics. So they're meeting with clinical teams and going line by line through the risks. So that piece of work has just started. So we would expect to see an improvement on that. So maybe at the next meeting we can update.
Okay, so one of the things we've talked regularly about the inpatient survey and the fact that it is random and done without, and so I guess I fully support that, and we've talked about it at Health Watch previously as well, because the local Health Watch feel that we are not asking our patients or all of our patients for their opinion. So I doubt there will be a change is what I'm going to think, but maybe Matthew you could have that. You're absolutely right about the quality of the, Leslie, about the letters. So first with DOC, duty of candor, we started with actually just doing it and now improving the quality. So the same thing would go around with the complaints. In terms of the safeguard, so the safeguard is the system in which we collect incidents and we send those incidents across to the organization and the change. So we had one band 5 person working in that team, and it was at high risk. So when I took on quality and safety last year, we tried to understand where we are. We need to procure a new system, but till we decided which system we wanted to go with, because we were working with Barts along with that, we put in a new, we moved staff around, we've done more retraining, we bought Safeguard in, and rather than one person be a single point of failure for us, we've trained all of the people within that department to use the Safeguard system. We, however, think that we need to probably go through a procurement exercise for a better system within that. We've put in or reorganized a team to have a band 7 that was advertised and closed yesterday. So we've got some significant, a lot of interest. So I think in the short term, we will mitigate it with the reorganization of staff around it. But in the longer term, we need to go through a procurement exercise to get a better system. And there are some really good systems that Kerry and DIP have looked at when they went to the Patient Safety Congress in September. The one around the tags, I have been busily trying to sign in as many as I can. So I think that's to do with the pharmacy, the personnel within pharmacy, and that needs to be signed off by me. Usually it's the chief medical officer who signs off the thing, and I've received quite a few to do before I finish, and I'm sure Andrew will receive that. The translation services, Hilary, we haven't brought it to QAC, but there's been a lot of conversation, and Catherine's been leading on this around the translation services in the organisation, particularly related to maternity. So it's in terms of the challenges of communicating with our vulnerable mothers. And there's a big piece of work that Gary has done, and in terms of how we procure, what is the offer available, and what are the options that we could do within different organizations would do and what we have. I believe we have made a decision to go with the system, and the clinical teams are giving us feedback around that. I don't know, Janine, if you know any more around that, but Catherine, sorry.
Matthew does.
Matthew does, okay.
Absolutely.
Yeah. Janine.
So, I mean, the particular issue is when we get late presentations in pregnancy or emergency presentations in pregnancy, we suddenly at short notice need to find a language that might be relatively uncommon. And so the translation service has got worked relatively well for booked appointments or appointments we've got prior knowledge. If you've got a woman who suddenly comes in and she's already in labour, our ability to find people quickly and promptly enough has caused us some problems, and some of the obstetricians and midwives have rightly raised concerns about that. So we are going to try to do some work to get after that, but it's quite tricky. We do get some of the language requests that come from BHRET are at the more complicated end of the scale. And so we're trying to think how we can be quite innovative about it, because some of the dialects, etc., are actually not ones that most of the translation companies usually offer. And that said, we recently had problems getting someone speaking Romanian, which is the most common language we have actually a request for in the trust, so it can be variable. So we've really got to make sure we kick the tires on that provision.
And we could bring it to the next QAC. We have done a lot of work.
I think so.
So we could bring it to next QAC, and we could have further discussion so that you could report it into the board. And in terms of the rhythm of overdue actions, I think where we are, the fantastic report that Linda supported is looking at risk and then getting into a rhythm of what risk looks like, and therefore the risk actions. I think we are working through getting into a rhythm for that. And I think we probably not the next board, but by the end of this financial year, we will be in a much better place in how we are approaching risk and the actions related to that. I think we've answered all questions.
I think you've covered all the points. Thank you.
I think so.
Thank you very much. Thank you. Moving on to the chair of People and Culture Committee's report. Leslie.
Yeah, just to pick out a few things. We've had some really good reports on some of the work that Janine's been leading on leadership and leadership training, which is making a real impact across the trust. We had a report on job planning. This feels should be handled as well, but it is absolutely worth putting in record that in 2023, 10% job plans were done, and now it's over 70%. And I think that is a real testimony to Mantha's persistence in actually getting this done. When I started here, all everybody talked about was job planning and nothing happened. People don't actually talk about it anymore as
They
an
do,
issue.
you don't know
They
about it.
Complain about it. You've done it.
It's a different level of, talking about it
Yes,
now.
yes,
It never gets raised here as an issue because it all gets stuck at your door when they know now. But actually, I think to have moved from 10% to over 70% in a little over 12 months is a phenomenal achievement, and you should be really proud of that. You leave us with a good legacy of having some job plans in place. You probably arrive at Kings and find they do no job planning.
I suspect I'm now
Thank you
known
for
as
saying
the
that.
job planning guru in the country. Everybody wants me to do job planning.
We had a really good report on preceptorship and the support that we give to our newly qualified staff. And actually that got picked up on the visit I did today, where some of the staff there were talking really positively about that. And I think one of the things we were certainly told that the real best possible demonstration of success of that is that people that train with us stay with us. And we were talking today about the number of trainee midwives who actually stay, which is a real testimony to the fact that the preceptorship scheme is clearly working, because those people feel incredibly supported in their newly qualified period and want to stay with us as an organisation. Though we had a discussion on recruitment and staffing levels, I think that comes up later on the finance anyway, so we should talk about it then, because there's no point in having two discussions on the same things. And the other thing really to draw attention to is the work on quality improvements in senior recruitment. Whilst we're now in a position where we are appointing equal numbers of BAME and non-BAME candidates, actually we shortlist on more BAME candidates. So there is still a disproportionality between shortlist and appointments, and one that we just need to keep pushing, and we are taking a range of initiatives to try and have reduced down that disproportionality as far as we're able to. I think those are the main issues. It's really some really good work now being done around leadership and staff engagement, which all feels as though that the work on training, the work on preceptorship, talking to somebody today in who is a local woman who is just about to complete her midwifery apprenticeship, and talked about how proud she was to be working in a hospital, to be a midwife, and it's what she's always wanted to do. And she started off as a MCA and now was doing her training and was very excited about the fact that she would be having two graduations next year, but she would have the graduation that we do and her university graduation. And I think some of the stuff that Kenya and Janine and colleagues have been working on, when you talk to somebody like that, as you walk around, you begin to feel like we are making a difference, because it's the way people feel. I have to say, 3.2% vacancy rate in maternity, which was, as you said, you don't even count 3.2% of the vacancy. So some of the work and fewer overseas people, French people coming in, we're now recruiting our own. So the work that we've been doing, I think, and that helps in terms of the work Vinny's been doing to leadership and culture. And actually it helps with that friends and family stuff, because the more of us that work locally and speak positively of us to their friends and family, they're our best advocates for the hospital. So it kind of feels as though things are beginning to come together a little bit. So that's my update.
Thank you, Leslie. Caroline.
I think that one thing that struck me as you summarise that, it's extremely well, and sort of the mood around things was, I think Matthew, was it last week, that you were talking about the recruitment of nurses, but from other parts of England.
Yes.
And the UK. And there was a line, and I'm going to paraphrase it, and it was your report, so you'll know much better. But around the reputation of the trust, the work that had been done was actually having that impact on being able to recruit and because people in Sunderland or Southampton, whether in the past wouldn't necessarily have done that to come to Romford, but they would because of the reputation. I think often you invest in training and development and these things, and it takes ages and ages. And then suddenly you get this really strong indication that you're doing the right thing, and it's actually bearing fruit. It might be a little while coming.
Thank you for that.
So I mean, I think you're right about that, and there's lots of different things can come together into that. It's been interesting. Things like moving out of special measures helps with your reputation. Things like the trust induction, the changes to that help. We bring people together, celebrate that, and it's interesting. I mean, I've spoken to two doctors in training today, both of whom have been here since August. One in neurosurgery, another is working up on Sky B, and they both talked about how positive their experience has been here, and how much better it was than they expected. And actually, how much clinical work they've been able to do, how good the super. These are like random corridor conversations with folk actually, but there is a sense of things moving at the minute. And I think the key thing for us to do is to capitalise on the opportunity we've got at the minute out of special measures, and that we've spoken to the consultant workforce this week in the regular consultants committee. I think probably the biggest risk to us at the minute, ironically, is around the money. Actually, and our ability to maintain control of the money enables us to do all these other things properly. We are in a positive position. It's been interesting. We're recruiting for a couple of senior posts at the minute. People are applying who said, "I'd never really have thought about working here before, but now we will." And that's because of strength and depth right across the organisation. Some of that is also because there's lots of talent within the organisation that we've been able to bring into more senior jobs too. But this stuff does take time. I've been here 3 years now, and I think some of these indicators are just starting to move in the right direction. I don't know if Janine wants to say about where we are with the staff survey.
Yes.
Just as a quick thing.
So headline press, we have already beaten last year's total with 3 weeks to go. We're at 44% completion rate for substantial staff. And for bank staff, we have more than smashed it. So last year, the bank total completion was 4%, and we're at 17.5%.
I think that's just another indicator. That was the hardest indicator. That's one indicator we haven't shifted since we're just starting to make inroads. So I think we've got some good years ahead of us if we can keep on this trajectory.
Thank you for that. Thank you. Moving on to Finance, Investment and Performance Committee reports. Sue.
Thank you very much. So I think we've met a couple of times since the last board meeting, covered a lot of ground, including a lot of business cases, and a large amount of what we cover at committee will come to board either in public or private in its own right. So I'm not going to labour the points that you will be able to explore in more depth. So I'm just going to try and pull out the things that aren't covered under their own agenda items here. I probably should start by saying we remain off plan, but our trajectory is improving, and we'll talk to you about all of that. Highlights that aren't covered elsewhere. We have agreed to bring to board a proposal around a memorandum of understanding for the pathology partnership, which is really significant for us in terms of partnership working and moving our services forward. Still a lot of work to do, but I think that merits highlighting at this point. We did receive a business case about fire alarms at KGH, which we've agreed because the value is below what needs to come here as a separate business case, so really just for noting. David has already talked to you about digital. We received our quarterly estates update, which is documented here. I think the thing I would like to say is we as a committee gained significant assurance from the way in which the leadership of the estates team operate within the organisation. Really insightful and quite commercial approach to maximising and optimising what we get out of our estate, and they are to be congratulated for that. We kicked the tyres on the Bath and will continue to do so. And then I think there's a whole pile of business cases that are noted here, but will come to the private board in detail, as will the paper on gynae, and you've heard about freedom of information update. We had quarterly updates around the activities of the procurement service, which is very useful. I think the thing the committee is most interested in seeing is how we are having a really pragmatic and robust approach to social value. We have significant buying power as an organisation. We want to make sure that we get the most out of that. We received a really excellent report on financial recovery that is really helpful to us in understanding how we're going, but Mike will cover that in his report. I think everything else is coming here in its own right, pretty much. So headline is some really good work going on, off plan, but moving in the right direction, and some good innovation happening through business case change. Thank you.
Thank you, Sue. No questions or comments. Let's move on to the IPR. Fiona?
Yes, I'm going to talk through the data. I mean, Matthew gave us a good introduction earlier to what we've achieved over the last month, but I was going to pick out a few of the areas that are particularly relevant to winter, just in terms of how we're preparing and what some of the information's telling us. So in AD, we know that we've had increased activity. We continue to see increased activity. This is a very busy hospital for emergency attendances, and I think it's fair to say we've held our own in terms of overall performance. But I think, as ever, the devil's in the detail around UTC, or UEC, should I say. And I think what we should really be focusing on is that we have yet to improve our Type 1 performance significantly. We track below the London and national average on Type 1 performance, and our position within London is much improved, don't get me wrong, but we're still in the lower end of Type 1 performance, and that really is the bit that we need to do as an organisation, the bit that we can make a difference to. I would say, though, however, by way of context, that within that data are the children we talked about earlier who stay days rather than hours, the mental health patients who we've seen increased attendance and use of our ED departments as a place of safety. And I think it's fair to say also that the performance for our ED department is equally split between admitted care and non-admitted care. It's very easy to think that the majority of the patients that wait a long time are waiting for beds, but I think that is not necessarily the case. And part of the reason for that is the sheer the environment that the REDs are providing services from. It's reasonable to say that King George's has had quite significant improvement in the last couple of years. It's got a department that is fit for purpose in terms of size, scale, and the physicality of how different bits of the department are organised. But when I was there last week, there were 11 security guards at the reception in the Majors area. And so you can only imagine what an impact that has, the crowding has, on flow for everybody else, for other patients, and assessment and coordination of care. Similarly with Queen's, they have done a sterling job, that team, of making the best they can out of the department that was not and is not fit for purpose in terms of size and design. And so we've got more to do, but I think we are getting to the point now where the next major step and opportunity in performance improvement over and above what we're already doing has got to be a new building, a bigger building that's more around ambulatory care, that's allows us to assess and treat patients quickly in the right environment. And that what we've got at the moment is a real mixed model of lots and lots of different types of patients, from scale all the way from resus down to frail and elderly care, including looked after children, and they're all in the sort of same space. And I think that's probably what I would say is the most important bit for us to be focusing on. That doesn't mean we've taken our eye off the ball on performance, we never do, this is business as usual. This is a constitutional standard, and we'll continue to commit to making the very best we can out of that. There's a slide on type 2, which is great news, actually. It shows you that if you come to us for an eye emergency or a gynae emergency, we are focusing our attention on making sure that you have a dedicated pathway that sees you as an urgent patient needing assessment. And if you look at some of the improvements that have been made in eyes, particularly in the last month, you will see quite significant work has been undertaken to make that better. The ambulances, I think we've heard a couple of comments about ambulances. We're going to undertake a pilot, and that's part of a London-wide pilot at Queen's Hospital, assessing the patients that are brought to us by ambulance, the reason for conveyance, the time it takes to hand over those patients, and when the ambulance crews lead. And I think this is an attempt by all of us to get a bit deeper down rather than measuring time, measure reason, cause and effect. And I think this will be invaluable in us deciding what the future looks like in terms of how do we work with LAS, how do we work better with primary care, how do we avoid patients being brought to ED as their first point of contact. And so I'll be delighted to share those audit results with you once we've started. I mean, it hasn't started yet, so it won't be next month. The next slide just gives you that sort of context I gave you earlier around how long patients are in the department. You can see the split by site, by children and by adults, and by admitted and non-admitted. And what's remarkable about this data is there's nothing remarkable in it. It's all similar. And that talks back to what I said earlier around physical space and increased attendances. The next slide is just a visual example of what Matthew said earlier around King George being now the 4th highest receiver of Section 136 patients in London, which we know can't be right, and there does need to be a sea change in how we do better for these patients and how we as a system create different spaces for patients who don't need to be in ED, and ED patients don't need 11 security guards around them on a day-to-day basis. So that has been and is becoming more and more of a priority for us with our partners. There's a slide on each of the sites which I won't go through, but it shows improvements, particularly at Queen's. If you look at the patients who don't meet the criteria to reside, the reason we do as well as we do and the way that we flow patients through the hospital is because we have systematically reduced the number of patients who are waiting medically to go somewhere else. And I think testament to Beth actually and the site team, who I know work really hard on a day-to-day basis. That's a daily challenge. It's not going anywhere, but we do and can show significant improvement in those areas. On to planned care. Matthew mentioned earlier the achievements we've made. If we focus on the orange line on the graphs, we can see sustained improvement and attention on reducing patients that wait a year or more. Even within women's health, where you can see the biggest rise in recent months, you can start to see the improvement, and that is the culmination of really hard work from the operational clinical teams, huge amounts of validation, and really doing some of the innovative work that Amalesh and the teams do every week to reduce the time it takes us to see, diagnose and treat patients. So this is a really good beginning. We are back on track in terms of reducing the size of the waiting list, reducing the length of time patients wait, a few bumps to go through, and finally just to call out specialist medicine, who have really delivered massive improvement in long waiters there. It felt like a never-ending hill for them for quite a long time, but huge amount of work, and that represents about 8 different subspecialties. It's not just one PTL, it's a lot of them. The health inequality slide is work in progress, and we are constantly looking at our PTL, specifically around planned care, but we're constantly looking at the totality of the PTL to see and look to see if there are any areas of particular concern with regard to the communities we serve, gender and age, and obviously there's learning disabilities in there too. So I would say that in looking at this data at this stage, we're going to start looking at this at a specialty level going forward. I think we do a bit of a rolling program on things that are what is the data telling us, but particularly around here, it's not surprising that women are the highest proportion of long waiters because of the size of the gynae waiting list. We are demonstrating good levels of care for people with learning disabilities in that there are only 4 patients in the total of the 1,200 that have a flag for learning disability in our PTL. 3 of those are gynae and 1 of those is neurosurgery. So they are closely monitored, and we do have a filter. I think you might remember when I first started here, we put a filter on the PTL so we can look at any time how many patients and who they are have a flag for learning disability. I think the deprivation data just is representative of our community. I don't think it's telling us our PTL is the same as our population that we serve. It doesn't mean it's showing us anything different, but there's always more work we can do around delving into and helping deprived communities get into healthcare. And the age demographic shows you that we're doing well, making sure our elderly patients don't wait long for planned care or too long, considering that is disproportionate to the size of the elderly population in our PTL in our hospital. I've mentioned 52-week waits. We're down to 1,100. That's great news. We will carry on. We will keep going. And I know the triple lock makes it a bit harder to do innovative things sometimes, but we are shoulder to shoulder, aren't we, Mike, on delivering that?
We might
Smile now.
Heads of sore.
So here, just a quick briefing here on RTT. The government, I think, will be expecting hospitals to start talking about 18 weeks again soon. It is happening. We will stop talking about 18 months and get into 18-week conversations. There's a big piece of work to do between now and then, and we haven't designed that yet, but it is coming. And so we will start to think about this slide more around delivering it rather than a context conversation. In terms of DMO1, no news is good news, I'm afraid, here. So 4.3%, we are compliant. We've been compliant for months. And if you look at the amount of imaging and diagnostic tests this organisation undertakes, it's staggering and it's brilliant. And I can't tell you how proud I am of all of the teams that contribute to that. 30 utilisation, fallow sessions down to 18. We literally waste nothing in this hospital anymore, and that is a great place for us to be. And theatre efficiency by subspecialty or by surgical specialty is something we keep a very close eye on, and actually they do really well. We keep measuring in it. It is part of our GIRFT plan care standard, so we will always measure that, but it's always nice to not have much to say about in that space. And I think cancer probably deserves a little bit more of a mention, and I think we could probably go a bit further with this slide going forward. Our area of particular improvement recently has been in streamlining the histopathology pathways, massive impact on cancer waiting times, as you can imagine. And I will bring next time, as part of this update on cancer, the kind of dramatic improvement that has been made in histopathology, and that's directly linked to a very well designed programme of improvement in histopathology, along with the investment we made just over a year ago of 4 additional histopathologists. So we knew that was the answer to the problem. A bit of pathway redesign, but in the majority of this development is really down to the histopathology team, the amount of work they do, and the innovation that they've brought into their service. So a huge well done to them too, and keep up the good work. The cancer referrals keep coming and they keep growing, so that is not going to change anytime soon, but just wanted to point that out. Thank you very much.
Thank you, Fiona. Impressive set of data. Awesome there. Any questions, any comments from colleagues? Sue and Hilary.
Thank you.
Leslie.
So I agree, Mabu, the trajectories and the improvements are fantastic, and full credit to everybody, because this is a real team effort, isn't it? I suppose my big question is, it feels like we've turned many corners here. Are we going to be able to sustain? So what's the evidence and the comfort that you can give us around sustainability of this, please?
Yes, thank you. Hilary and Elizabeth.
It was a question about slide 12, actually, of your question response to health inequalities on the PTL. You've mentioned that people aged between 35 and 54 are relatively overrepresented. They're 27% of the waiting list, but 43% of the over 52 weeks. And it just occurs to me that's an economically, well, you hope, an economically active stroke productive population. So do we understand that? Is it because they're actually saying it's not convenient for me and it's a page leave exception? Or is it that, you know, for whatever reason, we can't get people, because I'm West conscious it would get people back to work, and it's one of the downsides of the scale of the waiting lists at the moment.
Thank you. Sorry, Leslie.
Yeah, I was going to say it is really, you know, it feels as though things are definitely on the right trajectory. Would echo Sue's question about how sustainable it is. I suppose the challenge we've got is still type 1 in urgent and emergency care. I mean, if we could get that better, we really feel as though we are motoring. I was also going to pick up the point that Hilary made, and that certainly economically active age group is the bit that absolutely chimes with the government agenda about the importance of the NHS in getting people into work, but also picking up the deprivation one. I mean, I know we have high levels of deprivation anyway, everywhere, but it is sort of saying that they do account for a lot of our long waits, and it would be interesting to see when you've done the piece of work that sees whether there is any intersectionality, which I think the point Ruth and I raised when we looked at the gynae thing at Frick about is there any intersectionality between deprivation and the long gynae waiting list, and I think the data said there was, and I think that's a real issue because it means there is a group of women that we are not serving as well as perhaps more bushy middle class women that are making sure they get their treatment sooner than other women are. And there may well be language issues and all sorts of other issues around that we need to perhaps go a bit above and beyond to make sure we are actually reaching all the women that we need to be reaching. So when you do that piece of work that looks at the different pathways, it would be really interesting to see whether, other than gynae, whether there are any other pockets where we're just not quite giving people that equity that we would want.
Okay, so in terms of sustainability, I mean, you have to take each standard slightly separately because there are different things you do for each of the standards. But I think with the exception of the type 1 work, we've got a plan, and then we've demonstrated the sustainability already in most cases. I think you know, we are moving targets. So if you take ED, for example, the more conveyances we get, the greater number of attendances and the greater number of admissions. We lose traction. Then we regroup, redesign, and carry on. So we have, if you think about ED as an example, the way of delivering ED has had sort of 4 or 5 different initiatives. It's not been, just one type. We've got the Frailty Virtual Ward. We're opening St George's Wellness or Aging Well unit in 2 weeks' time. So I think insofar as we understand the problems we've got, we understand the operational clinical response to those problems for each of the constitutional standards, and we have a future plan that not only deals with the today, but actually innovates and tries to change the delivery system for a lot of these services. Because if you think about anything in UEC, let's be quite honest, the fact of the matter is that we need to provide viable, resilient alternatives to A&E in all hospitals. That's, I'm sure every hospital in London would say the same thing. And that is where resilience will come from. It will not be by employing more nurses in the corridor. It won't be having +3s on the wards and putting sinks in the bays to make it more comfortable. That might be a short-term gap to enable us to feel better about it, but it won't be a long-term option. And I think planned care is, we are an exemplar hospital for planned care. We know how to do this. We've got all of the ingredients of doing it well. I think I did say, I'll name drop now, but I did say to Jim Mackey on Tuesday that what we've got to start thinking about as an NHS is that planned care recovery is not about doing loads of operations. It's outpatients. It is, 90 odd, well into the mid 90s% of the work is dermatology and rheumatology and all the other ologies that need 2 or 3 outpatient appointments and maybe some scans. But so there is a sea change required if we're going to get serious about 18 weeks. The 52-week position, it says in the paper here, almost all of those long waiters are women. They are all on the gynae waiting list, and we know that some of them are waiting for procedures, but most of them are waiting for Urogynae services, which, if I'm really honest with you, should be provided in the community with specialist support from the hospitals. During the pandemic, those community services kind of just distributed outwards and didn't really exist the same way afterwards. And so all that happened was all the women that needed that service were given to secondary care. So I think we've got a plan. The women's health hubs will help, but also with working with partners around what the women need. Where does a menopause clinic need to be? Definitely doesn't need to be at Queen's Hospital. It needs to be somewhere better than Queen's, more conducive to holistic care and other areas of support. So I think we're at the beginning of saying confidently, we're going to be resilient. We know why people wait a long time, and we've got a plan for everything. But I do think we have reached a point where we understand what the issues are.
And if I could just follow up on the gynae issues there, about those are the ones that we need to be doing more vertically with our partners. And the Women's Health Hub in the Ilford Exchange is a good example of that. But it's about dealing with the current backlog and do it, but then it's dealing then with ensuring that the future demand is done properly. You lead for us on place collaboration as well. What are your thoughts around how is there a sense of prioritisation around that, and is there a sense that partners and others can contribute towards making that happen? What are the challenges for them as well, potentially?
Yeah. So I think, if you take women's health generally, I think everyone would agree that the ICB takes women's health very seriously. We've set up women's health, a whole piece of work around women's health. We've got 2 health hubs within our footprint, and what we do in the health hub is we pull from the backlog and the front end of the PTL. So we're preventing another backlog and we're reducing waiting times at the same time. So there's a direct, there should be a direct correlation between the improvement at the front end and the reduction of the long waiters. So that's a sort of tactical point that we've deliberately designed it that way. I think secondly, we work really well at place. We understand the problems that we have, and I think there are other areas like dermatology where we're starting to unpick the problems of the service that traditionally sat in secondary care, but actually don't really need for us to solve them. And so system working is, it's not easy. No. Because there's money involved, there's people involved, there's time and facilities. But I think if we prioritize the most impactful areas and get through those, we've kind of create that blueprint for close working and collaboration. And recently we've worked with NELT for example, in obesity clinics, we've worked with NELF to co-design a specialist obesity service for diabetics. And that has required NELF to provide us with health psychologists and other people getting involved in creating a multidisciplinary clinic, which is great and it's brilliant and it's really impactful for people. But I have to say, it's taken me about 6 months to navigate the resourcing of that. So I think the commitment is there, the want and the need is there. I think we probably collectively need to start being a bit more fleet of foot about how we share resources or ignore organisational barriers so that we can do things quicker.
Thank you. That's really helpful. Very much. Over to item 17. Finance report month 6.
Great.
Right.
Thanks, Raghu. Okay, so Matthew said that the financial context is very, very challenging at the moment, and it's a really significant organisational risk. Where we are after the first half of the year is we've got a £20 million deficit. We had a £10 million deficit plan for that period, so we've got a gap of 10 million. We have seen improvement. So if we'd have doubled what happened in Q1, we'd have been at about 25 or 26 million. So you can see that we have seen run rate improvement in Q2, which is great. And Fiona's just referenced fallow lists and what's happened there, and Janine will talk about some of the positive workforce metrics in a minute. And they're the kind of sustainable changes that are really driving the run rate in the right direction, but at the same time, it's not where we need to be. Having said that, when we set the plan, we did recognise there was significant risk, and the green, amber, red graph on the exec summary of the financial report shows the level of risk we thought there was, and we are kind of sitting in the middle of that at the moment. The challenge, though, is that there is no more money, and the finance recovery plan that North East London needs to put together is in iteration 3, I think, at the moment, 3 or 4. It's moved from £100 million unmitigated gap, and I think the latest version is about 60 million. Matthew and I and other chief execs and other people from North East London will be with the region tomorrow to talk that through and see whether or not we're at a place where we can get on with delivery, or whether or not we're back into searching for what else we could do. Clearly, the balance of risk and money is one that tough decisions need to be made. I would say that my biggest concern now is cash. So the cash forecast shows that the direction of travel with current levels of expenditure shows that we will kind of not have sufficient cash to be paying bills. We have made the cash application as the board approved a few months ago, but as yet has not been approved. So we're going to continue to work with the region and with possibly Treasury, because Treasury are the people that approve the applications, to see if we can push that through. Ultimately, the sustainable way of managing cash is to deliver plans, but we do recognise that the plan had significant amounts of risk in it. So it's very, very difficult at the moment. Capital is a pretty good news story. We are on track for what we want to be doing. We're also lining up, the things that we would want to do, but we can't yet afford to do, but we'll be ready to go for those things when either more money becomes available this year, which traditionally it does sometimes in the NHS, or we'll kind of look to be on the front foot for the kind of the beginning of next year. So I think that's what I'll talk about. Otherwise, I'll talk about some workforce stuff, which I know Janine's going to talk about in a moment. But it's a very difficult context. But I think people are really approaching it in a really collaborative and sensible way.
Yeah, so to build on the workforce, so the bulk of our spend is people. We are a people business. Okay. And so backing up Mike's point, we have seen excellent progress in terms of the clinical group in engagement. Their grip and control in the performance meetings is helpful now. We are moving very rapidly to 1 in, 1 out for medical recruitment, which hopefully will start to further drive improvements. Just to briefly put out highlights from the detailed people workforce report, we have continued to see a reduction in our total number of deployed staff, which is good, and we're growing our substantive workforce, using our temporary workforce, with the exception of one-to-one specialing and mental health nurses, which is driving an increase in our agency spend. I do want to further stress here that in spite of that, we are running better than we were running this time last year. So that shows, even though we're not moving as far as we would have hoped, we are still continuing to improve. So I think we're about £1 million a month less on temporary spend than we were this time last year. And we have introduced, so on Wednesday, yesterday, we moved to hard stop on agency spend, with the exception of mental health and corridor care, which, given that that's the group that is driving the bulk of the spend, that may have an impact on how much saving that actually does represent. In terms of our medical staffing, we continue to be able to attract and recruit consultants, which is great. And I think that's testimony again to the excellent work that Manta has done in thinking about the culture and making us a place where great doctors want to come and work. But we are still not seeing, this is where the group and control conversations ongoing with our clinical groups, but not necessarily seeing the expected reduction in the temporary spend, even as we're growing our substantive workforce. So we're continuing to work through that. You will see that our overall vacancy rate is continuing to improve, and our turnover rate is in good shape as well. In terms of next steps, we continue to focus, as I said, on one in, one out, and reducing that temporary clinical spend because it's very expensive. And then also looking at how we can make sure that we have adequate control about our annual leave. We're at mid-year. I'm very conscious that we don't want to drive a spike in our temporary spend in March. So we need to get ahead of that and make sure that we are running as we did it.
Thanks, Janine. Thank you. Anything else, Matt? Shall I open it up?
No, okay.
Caroline?
I had a question about agency spend, because it's always really difficult, I find, with recruitment, because so many people will say, why should I come and work for you when I can get so much more by an agency? And then other trusts act in competition and things like that. And I know that you've been doing some work with Barts previously around it. I just wondered if you had any update about how you've got to this stage with reducing the agency spend, because I think it's something that, I mean, it is a big achievement, but it's not something you can ever be complacent about, because as soon as there's an economic squeeze, that will be something that comes back again.
Yeah, please. Yeah.
So in terms of the, I think I need to first make a point I didn't make. So our target was 3% agency spend, and even with me saying that we've seen a spike, we're running ahead of that target. We're at 2% now. And the way that we have done that is by actually driving up our substantive workforce, because our staff have told us that actually having high numbers of agency staff makes it harder for them to do their job. It's a less pleasant working environment. And so what we're then finding is that, knowing that we have fewer agency staff, we're better able to fill vacancies, and we've now ended up in quite a virtuous loop, actually. So in terms of the sustainability of that, my expectation is that, and we're seeing this with our low turnover rates, that as a trust where we have high levels of substantive staff, safe levels of staffing, more people want to come and work for us. So I don't actually expect us to be going back to the need for the high agency. And we moved unilaterally to stop agency spend when we did. It's been 2 years since we stopped it, hasn't it? And we moved pretty much unilaterally on that. And so we're actually running ahead of the rest of North East London.
Brilliant. Thank you.
Yeah, thank you. We'll pick up this in private board as well, so that's helpful there. Thank you for those comments on that. If we move on to the Audit Risk Assurance Committee report, over to you, Sue, for your second opportunity.
Talk, indeed. Thank you, Mabu. So the primary highlight really of the audit risk meetings is the ongoing position regarding our external audit. We have not yet concluded our external audit, though I think it is safe to say that we are down to one matter really that requires resolution, which is a very thorny and tricky, highly complex accounting issue, which we will resolve. It just requires some time. And we are in actually a very good place with our auditors around it. We have full transparency and engagement, and I am confident that we will bring it to a conclusion. And I would much rather we take our time and get things right than we rush and then potentially face new challenges next year. And Mike is nodding at me because I think he's in full agreement with that. And very helpfully, through Mike's offices, we are well cited centrally, and there is broad agreement that we should get this right. So we will clearly come back to the board when we have reached the end of this journey. But at the moment, there is nothing that indicates that we will have an adverse outcome of our audit. The world of audit, things can change quickly, but right now we feel positive. We've just got a lot of work to do. That's probably the most significant thing to talk about from the audit committee. We have received, we obviously received the annual report and accounts, and those have come through previously. We continue to update through internal audit the progress on their annual programme of work. We did have a number of overdue actions, and we as a committee are concerned about closing out those overdue actions. But a number of those relate to an item that is on the agenda for the board today, and that will bring a lot of those actions to a conclusion. So I feel confident that we're turning the corner on that. We continue to get good assurance from our counter-fraud team, and that's all very positive. We have been reviewing the position around board assurance framework, and we will do that regularly. So probably the only other significant thing I think to report on is the ongoing work around our risk management framework. We've had the benefit of some work from an external consultant that has really helped shape, I think, the future of how we will manage and document and report risk. Having received that report, we've got some work to do to determine our next steps, but I feel very confident that a piece of work will move us forward to be an organisation that manages through its understanding and mitigation of the risks that it faces. There were a number of other items that are fairly routine items, such as losses and special payments, waivers, etc., that are all documented there for your information. But I think I have covered all of the absolutely key things, the external audit clearly being the most significant component of that committee.
Thanks, Sue. Thank you. Any questions, comments from colleagues?
It's probably just worth adding that because we didn't make the October date, that the trust's accounts have been consolidated into provider group accounts on an unaudited basis. But like Sue said, the national team said get it right. Don't do it wrong to get it done quickly, get it right. So, but just so you're aware, it has gone into the consolidated account.
Thanks very much. Moving on to item 19, managing declaration of interest, gifts and hospitality. So Linda, thank you very much for all the work that you have put into this since the audit committee meeting, so really appreciate that. So over to you.
Thank you. So you've got an updated policy to approve. It's been updated to comply with NHSE guidance and to address a number of audit committee actions that Sue referred to in her report. We had an audit undertaken about 18 months ago, and it highlighted what we needed to do to address the position. In relation to the policy, nothing new really in terms of what staff are required to declare, but more clarity in relation to how to do it. The key part of the report that I'd like to flag, as well as requesting approval of the policy, is to flag that we will be introducing the Declare system for declaring our conflicts of interest, and there's a programme of communications that we start. We're going to have a phased programme of rollout on that, and that addresses a number of the audit committee actions really in relation to how we declare, making it more transparent and really much easier for staff to be able to access to declare their conflicts. So really, I'll just leave it with the board for any questions. Thank you.
Any input and comment? I get mine. Stu?
It's not so much a question, it's just a comment. I think Linda's done an absolutely sterling piece of work here. And anyone who has read the policy is full of worked examples and simple explanations. So it is longer, but it's better for it, I think. And I think it will really help our workforce to understand why they need to disclose as well as what they need to disclose. And I think that is often the obstacle to people disclosing because they don't really understand why. And I think this policy moves that forward significantly. So I think it's a great piece of work.
Yeah. Okay. Peter.
I mean, just picking up on Linda's point, as well as it being easier for us, it's also easier for members of the public to register people's conflicts of interest and people's gifts, and they will also be able to register whether those who should be registering haven't.
Yeah, thank you. And I guess through your committee, we'll keep an eye on its progress, its implementation, and across all of our staff groups, and being able to report back to them on that through your chair's report. Yeah, brilliant. Okay, thank you very much once again, Linda, for that. I know it's been an enormous piece of work that you've undertaken, but the importance of it now is to get that system implemented and used. Item 20, NHS England annual self-assessment. Over to you.
Yeah, it is. It's just briefly, it's self-assessment we've done or we have to do annually for the training we provide in the organisation. This includes medical and non-medical. So Kenya and Louise have helped pull this together. And 3 challenges we put is around education supervision for doctors, the funding for training, which is around our allied health scientists, healthcare scientists, nurses, as well as the wider members of the organisation, and workforce challenges, which is predominantly around recruitment and retention in the medical workforce. What we've said we've done really well is SIM training, which is doing really good multi-professional training, as well as the use of the apprenticeship and becoming the main provider, attaining the main provider status. I cannot finish the board without telling you that we had a GMC review last week for acute internal medicine, and they were wholly positive of the journey we've taken and how well we've turned around acute medicine, and the fact that trainees have told them they would love to come back, and the ones that have come back have seen a significant difference in their experience from 2 or 3 years to now. So yeah, I think that's a self-assessment, and that's the GMC.
Thank you.
Thank you and good night.
Yeah.
Good night and good luck. Let's do it all again.
Yep. No, thank you for that, Mamta. I was just looking on board agenda part 2, whether we've got anything for you to report on there, but this wouldn't be your last action, but it is. So thank you very much for that one. Any other comments? If not, I shall progress ahead. On any other business, we have none advised in advance. Do I ever got an EV? Yep.
Okay.
Fiona.
Thank you. I just wanted to sort of service update for everybody. So we were recently asked to expand our mechanical thrombectomy service in lieu of the Royal London replacing their interventional neuroradiology equipment. So it's a short update just to say that we rose to the challenge of creating a 24-hour, 7-day-a-week mechanical thrombectomy service, which for those of us who've been around a while know that was a challenge in previous years. We have committed to providing that for a 3-month period in the first instance, and we are currently providing the mechanical thrombectomy service, which is for acute stroke, so treatment for acute stroke,
to a population of 10 million people. We're providing Kent, East of England and North East London, which is a 10 million people population. So I feel that I just wanted to mention in public board the amazing achievement that the team has undertaken to do that. We've undertaken 23 mechanical thrombectomies so far, which after 4 weeks is about the right amount. We expected around 77 to 80 activities. But in order to do that work, we have to be open 24 hours a day, 7 days a week. So no mean feat for everybody. And I just wanted to say that.
Great work.
Fantastic.
Yeah,
Just
really good.
fantastic.
And Andrew,
And that wouldn't have happened without the thing Matt did to get right and so on. and stuff.
Absolutely,
So
yes.
It's a good way to finish.
Yes.
no, thank you, Andrew, for saying that. Do you want to say anything about
Yeah,
Mantas?
just as I know we'll say about this afternoon, but this is Mamta's last board after around 2.5 years.
Yeah.
I think she's moving on to, I'll say, different things.
Clearly not better.
As Chief Medical Officer at King's College Hospitals, which is somewhere very close to my heart as well, having worked there for a number of years myself. She's been a huge asset to us as an organisation. She came in and has dealt with, as members of this board know, a number of very, very long-standing challenges within the organisation. And she's brought it to a place where when you attend the consultants induction now, people who trained here years ago are coming here again by choice because they want to come in here because of the improvements and some of the changes we made in the culture here in medicine. She had a fantastic input on a number of areas, whether that's the finances, the quality of the services we provide, the strength of the medical leadership team as well. And she's also been a wonderful colleague as a member of our exec, and we shall miss her a great deal. She is tremendously driven by the right values, and I think she's a credit to the health service. Actually, she's the kind of person we need to see more of in leadership roles. And I know our paths will cross again in the future, but we are going to miss her. But we've been very fortunate to have her the period of time she's been with us, and I know that my former colleagues at King's will likewise benefit from her fantastic experience. So thank you, Manta. All the best, and we'll miss you.
Thank you.
Thank you very much. Meeting effectiveness. Any comments on that?
6 minutes.
It's not bad. We'll do it. We're doing it.
Okay.
Item 23, questions from the public. I've not received any in advance. Mr. Walker, you raised your hand.
Yes. I just have two questions. If we go great. The first is about personal experience. I couldn't get NHS dental care. I did manage to get some. That I've subsequently read that that's potentially a killer. There's been a big increase in sepsis in connection with lack of NHS dentistry. But there's no coding, it seems. There's no real track of whether that's an issue locally. So my question is, has sepsis been increasing overall in the past 12 months, 5 months, whatever time period?
Thank you. Have you got a second question as well?
The second one is the London plan says that they're planning to increase London population by around 1 million over 10 years, predominantly high rise going up across London. Have you been in touch with the mayor, the NHS England? I hear about the big expansion plan for Queen's. Is there any research projections on how you're going to cope with this big increase in population?
Okay.
So we've not seen an increase in sepsis numbers over the last 6 to 12 months. As you said, we don't know the dental sepsis numbers within that, so we can have a quick check, but I'm not sure it would be possible to disaggregate that based on our current paper records. We don't employ or provide dental services as a trust. The only cases we'd pick up would be emergency dentistry that might come in through the ED, but that'd be in very small numbers. But not to my knowledge have we seen an increase in sepsis related to that. I do agree with your general observation though, about how difficult it is for people to access NHS dentistry, but that's a known challenge. And certainly I think something that I know the government's having a good look at actually. And on your second point, we're well aware, acutely aware of the increase in the population that's planned for this area through the 3 sort of place-based pieces of work we do with Redbridge, with Barking and Dagenham, and with Havering Local Authority and other partners. We are involved in conversations around this. We know, for example, here at Queen's Hospital, there's plans for just shy of 1,000 flats to go up in the old ice rink here. We know around Barking and Dagenham, significant new developments in Barking Riverside. likewise in Redbridge, around Whips Cross, etc. So there's ongoing conversations about this. I guess it's fair to say that we see the extra population come in. There's never investment in healthcare that's proportionate to the number of new people that come in. And certainly one of our biggest concerns around here is with the absence of primary care services, particularly in somewhere like Havering compared to inner North East London. We know a lot of that does manifest as urgent treatment demand or as emergency care demand. So we are having conversations with them. I'd say at the minute, I'm not sure there are robust plans to deal with those increases in population. There's conversations ongoing, but there's not necessarily the investment of the workforce there to deal with that demand.
I suppose there's also the NHS 10-year plan, which seeks to move more services out into communities and build on integration of health and social care services, because not just an aging population, but a more frailer and possibly with greater inequalities, and a larger proportion of the demographic will be an older population as well. So those demands, those challenges are ones that we collectively need to look at with our partners and also at London level as well. So thank you for raising those points. And then I think that concludes the meeting. The next meeting is held in the next part of this board meeting is subject to the 1960 Act, where we held in private. In local government, we had to read out the actual phraseology. And I was looking at Leslie, said if I don't read it out, I might get marked down in my annual appraisal. So thank you very much, everyone, for your attendance. And I just want to, I guess, flag one issue. Redbridge Health Watch have their AGM on the 17th of November. It's in the chat function. And thank you very much for the services that you provided as chair of Health Watch Redbridge. I know you can hear us, but we can't hear you. But I will. I have dropped you an email to thank you for that. But
can you hear me now?
We can. Oh, brilliant! Someone said.
Yeah. Thank you. So yeah, our AGM is on the 19th. 19th of November, Ilford Town Hall. Yes, I am stepping down after 11 years, 4 years as chair. I can't stay any longer. But I will be popping up from time to time. I'm not going away completely.
Yes, you're very welcome to come along to any of our board meetings. So thank you for your service. And that's a nice way to conclude our public board meeting. Thank you very much. Convene at 3:15.